As Antonio told, my name is Karsten Klabe, working in Düsseldorf. By the way, if you don't know where Düsseldorf is located, it's in Germany. And if you're a fan of Quentin Tarantino movies, the dentist in Django Unchained, Dr. Schulz, was origin in Düsseldorf. So that's me. My topic is, hey doc, do we need another mix? Keep a long story short. Don't know. So end of my presentation. Okay, some financial disclosure. First question, do we have the perfect glaucoma surgery? In my opinion, no, and that's why there is a yes. Probably we need a new glaucoma procedure. I started 20 years ago with glaucoma surgery. At this stage, medication, we've got started just with canaloplasty, and then there were some traps and tube shunts, and a second yes at this stage. I want to have some additional surgical options. So how about today? Oh, it's a little bit crowding. A lot of devices, a number of procedures, and so sometimes I'm thinking every fortnight the industry is joining me in the OR and offering a new procedure for glaucoma. So at this stage, no, we don't need any more procedures. 2 yes, 1 no. Okay. And how about addressing uveo? And that is the topic of our meeting today. Uveoscleral outflows. This story begins in 1905 as a publication of Heine, based on observations by Fuchs, and he observed with the cyclodialysis we are able to reduce the pressure over an intermediate period. And was promising, but we've heard it in the morning session, in the surgical day session, about the different approaches, that not all the approaches we had for the uveoscleral outflow, but more actual was the gold shunt implant, and at the end of the day it was not a really success. And then we had the CyPass microstent, and they offers promising results in IOP lowering, but on the other hand, we have some severe issues with endothelium cell damage. So if I have a look on this slide, a third no. Okay. So, but let's have a closer look to the different outflow pathways we can address with surgery. A lot of things were already told in the morning session by very good speakers. So let me summarize it a little bit shorter and a little bit more back to basic. So if you have a look on the conventional pathway through the trabecular meshwork, if you address this way, it's a physiological approach. There is no blood management needed, and up to 70% of the outflow resistance caused by the conventional outflow. So improving it or lowering the resistance makes sense. On the other hand, there is no effect on resistance distal to collector channels at the moment. We've seen the histological images of the hinged flaps. And there is a limited IOP lowering effect due to episcleral venous pressure. And there are, at the moment, we discuss 3 possible outflow resistance mechanisms: the loss of permeability of the trabecular meshwork, the collapse of Schlemm's canal, and the closing of the connected channels. And this image we've seen in the morning session as well. And you see there is trabecular meshwork showed in green, and there is Schlemm's canal, but Schlemm's canal is not a simple tube. There are some cylindrical structures, fibers inside, and then there is the ostium of the collector channel with hinge-like flaps, and that is at the moment hard to address with our surgical strategies. So how about the subconjunctival filtration? It doesn't compromise the physiological outflow, and it preserves the remaining conventional outflow. It does not rely on episcleral venous pressure, and that's why it's the most potent outflow mechanism we achieve with traps pressures lower than 10, especially for the treatment of normal tension glaucoma. On the other hand, due to the risk of fibrosis, of various reasons, and the need of blood management, there is a variability of an IOP lowering effect. And we heard it in the morning session, I mentioned it again. It's not solved these problems. So how about uveoscleral outflow? Yeah, it is a physiological outflow, and there is also no blood management needed. And especially in younger eyes, up to 50% of aqueous drainage are due to the uveoscleral pathway. We have a rapid aqueous absorption in the suprachoroidal space, and there is no risk of distal resistance or any floor effect. But on the other hand, there is a possible risk of choroidal detachment or iris cleft during surgery, and there is a risk of fibrosis. The fibrosis in the uveoscleral outflow mechanism is still unknown, and it's hard to manage. So let's have a look on the pathway a little bit closer. One specialty is that there is no epithelial barrier in the angle. But if you see this on this slide of a younger human and an older one, there is a difference in the anatomy. In an elderly patient, we have more fibrillar material tinted in light blue here, and that's why the portion of the uveoscleral outflow is much smaller, less to zero in elderly patient. So, but how about improving it? If we are able to improve this, I think it's a good chance to lower the pressure very effectively, though that is a yes for a new device. And here we see some really great papers, and this is from 1989 from Amy, showing the stable pressure gradient between the anterior chamber and the suprachoroidal and supraciliary space. The supraciliary space, there is a pressure difference of about 1 millimeter, suprachoroidal space about 4 millimeter, and that means a possible continuous outflow into the suprachoroidal space, and an immediate resorption ends up in an effective IOP lowering effect. And there was a paper about the drug application into suprachoroidal space, but it shows the ability of suprachoroidal resorption of fluid. So because there was injected a fluid with a micro cannula, and immediately the fluid follows the whole area of the suprachoroidal space. That means the resorption area compared to trabecular meshwork is 160 times larger, and that may be a possible good effect on IOP lowering. And therapeutic approach, very good known, and that are prostaglandins, and we know the application of 1 drop of prostaglandins offers us the most effective IOP lowering effect of all topical drugs. So, and the next step may be to address these outflow as a surgical approach, and in my opinion, it may bridge the gap between subconjunctival approach and Schlemm's canal approach. So the IOP lowering effect is not as much as we can achieve in a maximum trabeculectomy, for example. But on the other hand, the risk of scarring, the risk of blood management, late onset complication might be lower if we address the suprachoroidal outflow mechanism. And okay, there are some challenges as well. Iris cleft suprachiasmatic fibrosis. What we I think we are on a good way to overcome these challenges and address more. The benefit means easy to achieve, and at the end of the day, it works in every quadrant. So also in special situations. So, and that is what we are talking about today, about a new device, the Mini-Ject from iStar Medical. Details about the material, about the design, and on and on and on, will be given by Antonio in the next slide. That shows my surgical approach. I start with paracentesis for safety, clear cornea incision, 1 to 1.5 millimeter towards the center, not limbus based. A proper filling, I prefer to use Helon GV of the anterior chamber. And then here you see the tip of the injector using a gonioprism entering the anterior chamber with the injector device. And so I think a lot of you have experience with the CyPass. The surgical technique is, okay, we address the same region. We implant the Mini-Ject in the same region as the CyPass, but the surgical technique is a little bit different. It is because of the material. It's more like a sponge. So we have a stiff surrounding cannula we inject. So it took a little longer, and we have this green ring as a mark, which shows the level of the iris space, that it's not exposed into the anterior chamber for prevention of a possible endothelium cell damage. And what you've seen in this video is that we induced during injection a slightly larger iris cleft. So I've done 15 or 17 cases as long, because it's on the market since December, and I've never saw a case where these iris cleft not recovered within 4 weeks. So at the end of procedure, we see a light bleeding. I didn't have any severe bleeding in all of these procedures, and that if you fill up the anterior chamber after removing the viscoelastic properly and pressurize the eye up to 20-25 millimeter mercury, then in my hands there is no high risk of bleeding, postoperative bleeding. So which are benefits, and do we need another mix? Suprachiasmatic space bridges the treatment gap between subconjunctival and Schlemm's canal outflow. It spares conjunctival and the conventional outflow for further treatment options, and it can achieve meaningful reduction of IOP. The results of the studies will be presented by Antonio, and at the end of my presentation, I see a more, yes, we need another mix and we need a suprachoroidal approach. Thank you for your kind attention.